Tonight we've got two, repeat people who are coming here to talk now about some of the really critical services. Each of them has talked about a specialty. Now we're going to talk a little more broadly about the cancer services, both diagnostic and treatment, and all the options we have. I can say it was almost 10 years ago that my mom was diagnosed with intestinal cancer, and instead of having to go every day to Boston, she got treated here in Milford, and it's just been fantastic what it did for her, not having to fight the traffic for an hour and a half each way, and then having the same physician take care of her, for the last 10 years, just helps her compliance level stay high. So why don't we start, even though you're old timers, with introductions.
Okay, well, my name is Peter Oreo. I'm the medical director at the Dana-Farber Bergman Cancer Center. I'm proud to say we have one of those in Milford, Massachusetts.
And I'm Tanya Lingos, radiation oncologist. I work with Peter, and I also do network development in radiation oncology for Dana-Farber Bergman Women's Cancer Center.
So now he's going to have to really step up his game because we've got an emergency battlefield physician coming in pretty soon.
This is true. This is true. You're going to have my wife on in about a month or so.
I'm going to say.
So it'll be interesting. She's got some good stories for you. She served in Iraq and was a military-trained trauma emergency medicine physician. So it'll be an interesting conversation, I'm sure.
Yeah, I'm sure that what she saw in Iraq was very different from what my darling bride and I saw, because from 80 to 84, we went there several times a year, but it was much quieter, at least where we were.
You went for vacation, for holiday?
No, not vacation, for business.
For business?
For business.
Wow.
I mean, the closest we came to the front was not by choice.
Right.
It was during the Iran-Iraq War.
Right.
So we came too close, and service engineers we had came very close. Wow. But you had to go and service the accounts. You had to take care of the people.
Yeah, absolutely. Not a stable time at all. But
no,
yeah.
But compared to what your wife and our finest are going through when they went there this last time, and even now in Afghanistan and all, it'll be an interesting talk.
I'm sure.
So, Dana-Farber in Milford.
It's a beautiful place. Have you been down?
Yes.
Yeah. No. So we've, as we were talking, and as Tanya can attest, because she was very instrumental in building the centers out for us. We put this in 8 years ago now, close to 8 years ago, and we've brought just outstanding care, closer to home. The whole model is to bring, basically world-class care closer to our patient's home, because we know that travel becomes very problematic, and it's difficult when one's dealing with a cancer and all of the different sufferings that go along with it. And if we can bring care closer, as with compliance, as you were mentioning, it's easier to access, but it's also nice to know that you're close to family, friends, and going to and from become much easier.
Well, I mean, it's not just the strain on the family, because let's face it, if you need to meet with an oncologist, you're going to do what you have to. But leaving the center of the universe to drive an hour and a half to Boston, my mother seemed so much more relaxed. The tension level, everything seemed much better when she could just drive down, to the little, can't call it the Little Red Hospital anymore.
Not anymore, not at all.
Ed Kelly and even Frank will come back and kick me.
That's right. Well, they've done a remarkable job.
It's pretty amazing. Why is the Farber here?
Well, I think it was many, many years ago that Mona Kadis had a vision, and I think Frank Saba had a vision as well, and the community was so... The fascinating thing about the Milford community is that it's really a glue-like stick together, and we're stronger when we are together than when we're apart, and people really said, we want this, and others looked around and said, it doesn't really make much sense for Milford, Whitensville to have a cancer center. But Mona really was committed to it, and she met with a lot of the doctors in Boston, and the people in Boston felt that they had a vision that they saw that cancer care is really spreading out to other parts of the world, and you're going to do a better job if you can facilitate and have sort of satellite centers. So people started talking, and bridges were built, and it was a program that there was a vision of Larry Schulman and Frank Saba and Ed Benz and Jay Harris and Mona in particular, and they made it happen. And then Mona recruited Mike Constantine, and the rest was history. So it wasn't easy. There was a lot of resistance on the part of some of the people in Boston who felt that you really had to stay in Boston to get the best care. And so what happened was the model was developed that we would have doctors who spent time both in Boston and in Milford. We would have open communication with the two departments. And when we set up the center 8 years ago, 8+ years ago, the need was there. The need was huge, and the state saw that the need was there, and so we're able to put a linear accelerator in there in conjunction with chemotherapy and medical oncology. And if you build it, they will come. I mean, it's just been quite astonishing to see the way the volume and the loyalty of the community has been. And what happened is the programs have built upon one success after another. So we started with fairly common diseases, prostate cancer, breast cancer, lung cancer. And we worked very closely with the doctors in Boston to set up common programs, policies and procedures, making sure that everything was done the same, everything was done electronically. We had WebEx conferences so that each week, every new patient that we saw in our department was presented to doctors in Boston so that we could really legitimately say this is the treatment that you would get if you were traveling to Boston every day. And slowly it happened.
Well, I can see a huge benefit to the residents of Milford in the area. But why would Dana-Farber invest all of that to come all the way out here?
Well, I think when you sort of look nationally, that's where the care model. We know that patients, if they have the ability, would choose not to venture more than 20 miles from their home, and rightfully so because of the cost of travel, time away from work, some difficulties which you encounter. But also too, you want to sort of bring care to people locally because you really know there's only so much infrastructure. I mean, as you know, trying to commute to and from town, the roads will only support so many people going in. And so even if everybody wanted to go in, it becomes problematic. Gridlock, an hour-and-a-half commute becomes 2.5 hours. And with radiation, typically it's a protracted course of therapy where you're receiving daily radiation Monday through Friday, for 3 to 6 weeks, depending on the malignancy or the cancer site. And that's an awful lot to ask. And so I think there's, a benefit to the Farber too to sort of bring the care localized and so people can access it better. And obviously we want to try to, we live in Massachusetts, one of the greatest, states for healthcare in the entire country. And why regionalize what people can get? Why not bring the best care out to everybody? And as Tanya was speaking, we have done that, I think, very well in the sense that we now have 12 radiation oncologists that kind of rotate through. We started, what about 3?
One.
Oh, 1. But, we've been able to now focus our practice. So I treat prostate cancer, Tanya treats breast cancer. So you can really bring that expertise locally. So you don't have to go in to see the disease site expert. You can see that disease site expert close to home. But with also close continuity of, the weight and the power of the Farber and of the Brigham, where they have multiple disease site experts. But you integrate into those services, you can bring out the latest technologies, protocols, potentially clinical trials, things that a lot of patients just would never have access to just because of the geographic barriers which exist.
Well, I think one of the biggest concerns that you hear, and I'll let you talk to it, is, okay, if I really want the best treatment, I've got to go to Binney Street. I've got to go into town to the Farber.
Right.
Fact or fiction?
Well, I think it's like everything else. There's some malignancies, pediatric malignancies, you're probably better off making that trek. Some of the liquid tumors, the leukemias, things of that, which are very acute in nature, which require very, very specialized care, possibly that you'd be better served there.
Percentage-wise, though?
About 3% of the malignancies.
I was going to say, realistically, I've heard 95% can be treated here in Milford.
Right.
And that's the truth. I guess we don't want to sound that, we can do everything to the best, but the truth is we can do 95, 98% of it very, very well.
97%.
So.
And the way you do it here, any different from the way you would do it in Boston?
It's identical. So across the board, we have policies that we follow with one another. Our physicists are all of us are on the staff in Boston, and all of the staff in Boston are on staff here, and same thing with our physicists. So a lot of us trained there or worked there, and we have similar policies. The beauty of it is actually that here in Milford, we are more flexible and a little bit smaller. We don't have the big bureaucracy, so sometimes when something new is they want to pilot something new, or they have a new program, they'll say to Milford, Peter, why don't you take this into Milford and see if you people can do it there, and if it works, then we'll bring it into Boston and adopt it. And it's more computerized types of things. So we, radiation oncology is a very structured specialty, so that there are criteria that you have to follow for everything, and it's very detail oriented, and we have all across the board all of those details. And every Tuesday morning, every new patient is presented, and when we present that patient, we have our entire group from Milford and our other locations, as well as the Boston group where we have physicists and a Boston doctor, and we'll say, well, in Boston, do you do it this way, and how are you doing it that way? And then there was another patient today who was discussed, who was a complicated case and a young patient, and the consensus was that yes, that would be good, but you know what, let's just be certain, and we're going to present the case tomorrow in Boston. So that patient's case will be presented to the entire group in Boston tomorrow, and a decision will be made. Is that one of the 3% that needs to go into Boston for treatment, or will
But
that
the
person-
3%, is that more dictated on a specialist skill or equipment?
Well, I think when you sort of look at cancer care, it's a multidisciplinary approach. And so, radiation oncology, we are blessed, honestly, with all the, nicest and greatest technologies out of Milford. Our medical oncologists are top notch. Chemotherapy is something that comes from a pharmacy, which can be infused into the body. But sometimes when you have very complex tumors and complex portions of the body, or near critical organs, which there's not a whole lot of room for any potential error, what you're doing is you're bringing in the surgical weight or subspecialties. You're bringing in the radiologists, the interventional folks. Not that we don't have incredibly good ones in Milford, but we have folks that's all they do for a living. They specialize in this quarter inch of the body.
Right.
And there are situations, it's infrequent, but there are situations where the tumor is so complex that you'd want to know, okay, I've touched base in Milford. They're giving me an honest opinion saying, well, I think we may be better served, at least having an opinion, or possibly having, an intervention, and we can continue care back out here when that piece of the puzzle is complete. A lot of times with cancer care, it's a multi-step process. There might be surgery, there might be chemotherapy, there might be radiation, there might be different types of radiation. And what our job is really to sequence that so our patients are able to get the best care possible.
Well, now, when you look at the 3%, I mean, realistically, I'm not giving up anything by starting in Milford.
No, you're probably gaining as well, because the majority of stuff, I think as Tanya could attest, would sort of be taken care of easily without much issue, and it saves trips and time because you really are accessing all the experts and you get accessing the same policy and procedures. But you're also having an expert who I think I think what defines a person is to know one's limitation. And if you sort of know you're a little past your limitation, we have safety nets, if you will. We have thousands of individuals, thousands of physicians standing right behind us to jump in line to help out. And that's pretty powerful. I spent time in the military, as you know, and I've been in other cancer centers, and you see how you don't always have all of that expertise, all of that power, which can be tapped into. And it's nice to know that that power exists, or that that expertise exists if need be. And so I don't think you're losing anything, honestly.
But realistically, then, if I come to Milford, it may be that, okay, this tumor happens to be, like you say, in the place, that there's a surgeon or an oncologist in Boston that's done more of that than anybody.
Right. Right.
So, okay, why take a chance?
Exactly so. My mother, unfortunately, as your mother did 10 years ago, she's actively going through different cancer treatments where the disease is sort of throughout her body. And the truth of the matter is you start to sequence that this is the person who can do this is the person who can do that, and this is the person who can do all the other stuff. But you can start to pick and choose and make sure that the right things are being done at the right time in the right place. Now, necessarily, does it all have to be done in Boston? Absolutely not. A lot of this stuff is taken care of locally just as easily, but sometimes you just have that one little thing that you want the person who's done 1,000 cases,
Right.
Versus 50 cases.
Well, you mentioned pediatric. The caseload has to be a lot smaller.
Fortunately, very small.
Thank
Yes.
God.
Yes, right.
So if you do, unfortunately, need that kind of skill, it's nice to know that there's somebody who's done more of it than anybody.
Right.
And pediatric oncology is a really subspecialized area. So we don't treat I don't think we've ever treated a child here in radiation. But we generally do not treat pediatric patients here, but we know that we have access to the Jimmy Fund, which is one of the best in the world. And
It's just rated #1, actually.
yes,
Oh,
exactly.
cool.
It was.
Yes, it was. And so, and those patients are really treated on very special protocols. And so, I think that as what Peter's saying is, you take the ego out of it. The question you always ask is, what's the best thing for the patient? Yeah. And if you can't honestly say it's fine for the patient to stay here, or if you have any doubt about it, we just send an email to our group in Boston, and we say, okay, who's the best person for this? Or this is the question I have about how to manage this patient. What do you think? And then they'll...
Yeah, just one of those quick emails that says comments.
Exactly.
That's
Hey, has anybody got something that I'm overlooking?
Right, exactly.
You know,
And-
in the 3%, or there's a skill set I didn't know that you just hired somebody.
Right.
Precisely.
Well, it's that whole, that 10,000-hour concept of becoming an expert in something, but that email might be attached to 50 people who have 20,000 hours, and now it just becomes exponential.
Right.
You know, one of my favorite things is, as you're saying, is, what's the best thing for me? And the patient will often ask, what would you recommend for your father? And I go through it, and I always end the conversation with, "You're lucky I like my father." You should have asked that first.
It's funny, when we were running an antibody production facility, I had the same question when somebody would say, "What do you think I should do?" And I said, okay, that antibody could end up in your mother, your brother,
Right.
or your daughter.
Right.
Yeah.
What would you do? And then all of a sudden, people knew.
Yep.
Clearly.
Right.
So asking you, if I was your father, how would you treat me? I don't know if it's a fair assessment, but at that point, I don't care about fair, you know?
Well, that's exactly. I think that's a kind of a courageous thing to ask at times, because, as physicians, as educators, and there's oftentimes many appropriate treatment options, but they might diverge a little bit from each one. So there might be some difference. But we all have our favorites. We've all seen things play out. And, in this generation, especially with the internet and coming in with lots of information, it becomes more of a discussion of, okay, well, this does this, that, and talking about managing side effects and potential outcomes. But, that really cuts to the core. What would you do for a family member? What would you do for yourself?
And you think about it, it's so nice. When we grew up, you always heard about MGH, man's greatest hospital, right? And I always knew if I asked the people there, they would explain it as such. But now you have so many options.
Right.
When you think of the whole Harvard hospital network,
Right.
pretty amazing within 30 miles what we can draw on.
We are so lucky to live in the area we live in, and there are times that there are certain situations where maybe MGH is the only hospital that offers it, or the Beth Israel is the only hospital that offers it, and we can certainly set that up and facilitate a referral there as well. So as we said, you always have to do
you
what's
think of
best.
children's, if there's something very specific, it's not like they're going to say, oh, you're not part of our network. We won't
Never.
look at your patient.
Right.
Absolutely not.
Right.
Well,
Yeah.
that's the thing. I think very few folks will go into healthcare unless it's a calling in a way. To become
It's a
physician.
passion.
It's a passion. And honestly, you strip away the buildings, and you strip away, sort of who you work for. At the end of the day, you went into this because you want to take care of somebody.
Well, we've had this discussion over and over with so many kids that I help out, like at Holy Cross, where, they go into pre-med, and I point blank ask them, is this your passion? Because I know you won't like me for this, but MDs work way too hard for not enough money. Yes, there's a percentage that do extremely well.
I do a lot, because I went to Holy Cross too, and I have the shadow program where the students will come out and shadow. But that's one of the things you have to really assess their motivation and their desire, because it's a lot of work. You basically have to say you're going to give up your 20s, your early 30s before you can even do what you
Peter,
set
by
out
the
to
time
do.
you graduated the Cross Medical School, your specialty, you're ready to retire before you start earning money.
15 years later. So, it is a commitment, and that's the thing. And you want people to be happy. And I think it's our job, too, to sort of, we have experience, we have wisdom, we have a few more gray hairs, and we can say, this may or may not be for you, because exactly it's a wonderful profession, but it's a lot of work.
As long as you have the passion for it. Going into medicine, when we first started here in Milford, one of 4 physicians brought you into the world. Wow. That was it. I mean, you could be a Cicchetti, you could be a Mastriani. I mean, we can go through all four.
Wow.
Because there was only four bringing you in.
That's great.
And they all threatened to take you out if you didn't behave.
There's something to that.
You know, I mean, today, it's so different.
It is different.
But in a way, it's not. Because, you know, if I ask my mother, you know, it's still Dr. Mona.
Right.
You know, 10 years later, I mean, there's a magic about the medical center.
You know, that's exactly, and that's something it's taken me a long time to realize, and I've been doing this, for 15, 16 years now, but, you know, just going to visit my parents who live in the same house that I was basically born in. And, you know, sitting around the table, my mother talking about her physicians, like they're family members, and
Yes.
actually having some of the fellows over for dinner.
Yes.
And I'm thinking, there's a high probability someone may be talking about me right now. And that makes you feel good because you realize how much love and how much trust and how much, when you really make that connection to really help someone, you've changed someone. You're doing a positive thing.
Especially your field. I'm at a irrational point in my life. You know, when a family member has been told they have cancer. There's no, yes, I can think straight about a lot of things, but no.
No, you go into a tailspin at that point in
At
time.
that point,
and you walk
all
in those
logic,
doors.
it's all emotion.
Right.
And I'm trusting.
Right.
I'm trusting Dr. Mona with my mother's life.
Right. Right.
My God. You know, how does it start though? I mean, I don't imagine anybody wants to come and see you plant seeds. you know, we laughed before saying, okay, all this degrees, if it was my dad, he'd say, so you're a farmer? You go in and plant seeds? 15 years of training to be a farmer?
Oh.
You know, so nobody just calls and says, I want to come visit you. How do people get to you?
Yeah, well, that's exactly, and I think, you know, we'll both talk about this, but screening programs. You know, we talk about prostate and it seems to be a little invasive, and some, you know, guys will kind of shy away. And unfortunately, you can't put your head in the sand. Either you have something or not. You want to know you have it in an earlier stage when it becomes very curable, versus in the stage when we're just trying to ease pain and suffering. But, you know, that's where we give our primary care doctors, you know, a tremendous credit, because they're the ones where it all begins. I mean, a good primary care doc is your doc, your general practitioner, the one who, you know, might have seen you be born and it's kind of watch you grow. But putting the screening in place for prostate cancers, or breast cancers, colon cancers, lung cancer, and just making sure that, you know, one, we're living healthy lifestyles, but, you know, it's a little bit of luck of the draw,
You know,
unfortunately.
you mention it because I am an old man, so I want to be manly, right? And the whole idea of not being able to pee or salute on demand is a scary thought.
Yeah.
But let's see, behind door number 1 is death.
Right.
I don't care what's behind number 2
Right.
or 3.
Right.
I don't want to take door number 1, so not being screened because I'm worried, to me seems like the silliest thing you could do.
Well, and that's exactly it. And if it's caught early, especially in a prostate cancer with the PSA test, or even, you know, sort of a digital rectal exam, which seems to be invasive, but it can be very telling, you can invoke therapy, which allows you to pee and to salute. But if you allow it to go too long, well, yes, that you're going to be robbed
Yeah,
of
then
that
it's
function.
palliative care. I mean, you're on that spiral that leads nowhere good.
And same thing with breast cancer. And it's you go for a mammogram, and if it's detected at a sub-centimeter, millimeter size, smaller than what we can see practically, easy surgery cures it. You don't have to have a mastectomy. But people are frightened. And I think a lot of cultures also have such a view of cancer being a death sentence that they don't want to find that out. And ignorance, would you have your head in the sand? It's not really the way
Well,
to
I
proceed.
think a lot of people view it as I must have done something wrong.
Is a punishment. Yeah, no question.
You know,
no
now if
question.
you're smoking 4 packs a day, yeah, you probably did not do the best thing for your lungs. But
Yeah. I mean, a lot of it is just random genetics. It's things that we have no control over, and you know, it's sort of unfair. But
no matter what,
happens.
even if I've been bad or not been good my
Right.
whole life,
Right.
I look at door number 1.
Right.
You know, we went through it on, you know, breast treatment. No, you don't want to deal with the ultimate.
Right.
But wait a minute, the next step is door number 1. Don't care. You know, I'm sorry. You know, when I think of my best friend, somebody who's been the rock of our family, I really don't care.
Right.
You know, I don't care whatever you have to do it early.
Right.
And that was the problem I had with this whole argument about mammograms. That statistically, they don't merit early mammograms.
Right.
Unless it's my mother, unless it's
Exactly.
my wife or my daughter.
Or you, because male breast cancer is
Hello.
something that we don't talk much about, but it happens to, what, 5,000 guys or more
Yeah.
per year.
Yeah.
So, yeah, I mean, we kind of we make these very stereotypical, but the reality is it affects us all, and we
Well, I
need to
think-
pay attention to it.
The treatment is a lot more sensitive towards women.
Well, absolutely.
Because when they found a lump, both sides, they just went and took it out back then. It was 30 years ago.
Well-
You're a guy.
Right.
Who cares?
Right.
From out.
Right. Right.
Well, I think that's where a lot of the misnomers exist, because we're raised by our grandparents and our parents, and we're generations now removed from when things were caught because we didn't have the right imaging, we couldn't really look in the body. We were seeing things was much more advanced, and so cancer did come with sort of scariness and a bad prognosis because it was caught so late. But now we have the abilities through CAT scan screenings, blood tests to pick things
Peter,
up
what
much
you're saying
sooner.
is it still could be. If I let my ego get in the way
Absolutely.
and I wait too long,
Oh, yes. Right.
yes, this digital exam, well,
We see it all the
I'm
time.
sorry, nobody that I know of looks forward to that.
Well, nobody looks forward to a mammogram either.
Well, yeah, that's, which is true. But I mean, somehow when
Well,
you have it, and you say, "Please stop at the elbow," But all kidding aside, door number one is there.
Right. Well, and that's the thing. And if it happens, unfortunately, when we talk about prostate cancer, it likes to go to the bone. So it starts in the prostate, but inevitably it's going to leave, and it's going to find its way, someplace else, typically in a bone. And how do you find out? Well, when you're walking down the stairs and your leg breaks, or you have this unrelenting pain. So you didn't get past it. You didn't cheat it. You didn't
Right.
hide from it.
Right.
It found you, but it found you in a very bad, bad position or a bad way.
Some of the stuff I can understand. I go for my annual physical,
Yeah.
and they do the PSA test, and off you go. I self-examine breast tissue. Okay. Then when I go once a year, I have trained hands,
Right.
examining breasts.
Right.
Those two, okay. I'm sorry. To me, seems like a no-brainer.
Well, for 30 seconds of potential discomfort for your life or door number, not going through door number one,
Right.
that 30 seconds of embarrassment, discomfort, or whatever it is a small price to pay.
I mean, every woman I know talks about how much they hate being smashed, smushed. Okay.
But it's
if you
still
can
worth
find it when it's yay big,
Right.
and now it seems like the technology with the 3D.
I think that the 3D technology is very interesting and very promising, and it really has demonstrated that it can pick up more lesions than the standard 2D mammography. The other thing is that ultrasound has really come a long way, so that ultrasound is being able to detect a lot of lesions in dense breasts. So the screening is much more effective now. It's really much
But it
better.
all starts with your primary care physician.
I think so. And and if your primary care physician doesn't suggest it, then there's no harm in you asking for it. But prevention is really a big push right now, and with the electronic medical records that are coming in, they'll actually have a reminder up on the screen that says this patient is overdue for mammogram, or this patient is due for colonoscopy.
Oh, Uncle Phil will love you for talking about his electronic medical records.
I think the other thing is, routine physical exams. I mean, let's not forget about skin cancers and melanomas, and looking in the mouth now with these oral cancers that are becoming more common with HPV infections and that sort of thing, that those are easily detected just with a quick once-over, and it's important to check those
Okay,
things out.
how do I look in my mouth?
You go,
So not a big deal.
it is not a big deal. It's very
Well,
easy.
honestly, I mean, dentists send a lot of patients
They sure do.
because they're cleaning teeth, they're looking around, they might see a lesion on the tongue or on the
You see some
cheek.
cells that don't make sense.
Yeah, it doesn't look right, and they kind of sequence care. And it's amazing how many malignancies of the head and neck are picked up just from our dental colleagues,
Right.
because that's
Right.
what they're looking at and that's what they're doing.
Right, right.
And and then just you mentioned with HPV, it's kind of a scary thing. It's sort of a sexually transmitted disease, which it's very prevalent in the population, but it can, at the right serotypes, proliferate cancer cells. But those cancers are typically very curable,
Right.
if they're caught
Right.
early.
If they're caught.
Right,
Yeah.
right.
I mean, this whole STD thing, when we were kids, you'd laugh at somebody who had to go bend over and take a needle in the bum of penicillin. Okay.
And it's very different now.
And it was done.
Yeah.
Except for your ego and, you know, everybody laughing at you.
Right.
Okay. Today,
They
I mean,
mean
that's a
business
scary
now.
movie because
Yeah.
what's out there, you know, all of a sudden, monkeries would seem a lot safer to me.
That's exactly.
You know, I was like, thank God I got over that,
Yeah.
you
yeah.
know, because, my Lord.
Yeah. But there are other preventative things which are possible. I mean, with these HPV, the human papillomavirus, there's a vaccine that's very
vaccine?
effective, yes. And at first they were recommending it just for young girls, and now they're saying even boys should have it up to a certain age.
Yeah, I never understood what it was. Okay, normally it takes 2 people. Why would
Right.
you only care about one?
Right.
I guess if I had a son, and I lived in an estrogen palace, so boys were not something we wanted to think about.
Lucky
but
you.
if I had a son, why wouldn't I want my son just as protected
Right,
as
right.
my daughter?
And they are coming out with recommendations now for boys to be vaccinated as well, but it was a little slow in coming.
Yeah. Well, I think a lot of the mindset at the beginning was to prevent cervical cancer,
Correct.
which is a female disease,
Right.
but then they realized, as you say, it takes 2 to tango. So you want to protect both because we become vectors where you can
Right,
bring
you,
things
you
both
become
to
a
and
carrier.
from. Right, exactly it.
So now something isn't right. My primary care physician says, I want you to be looked at. What happens?
Well, it depends on what type of thing it is, but generally you have to go through a diagnostic evaluation, and lots of times that would include x-rays of whatever sort. Plain x-rays, ultrasound, CAT scan, MRI, or something like that. And then if something is detected, then you need to go to a biopsy. And you either have that done in radiology. This is one of the reasons
So
why
at
Milford...
that point, they'd be sent to the
hospital.
Dana-Farber,
Well,
the center.
we only see patients who've been diagnosed with malignancies, generally speaking.
So they're in the main
So they're at
hospital.
the hospital still, yes. And I think that when you asked earlier, why did Dana-Farber choose Milford, I think that they appreciated the fact that Milford was committed, even though it was a small community, they were committed to stay technologically up to date. They emphasize quality, they emphasize safety, and so you can go in there and get something done that's very effective and very accurately
So I go over
interpreted.
to the Hill Center or somewhere, I get poked, prodded.
Right, right.
Now, you have a linear accelerator in Milford?
We sure do. A beautiful one.
I mean, I had a hard enough time understanding how they got Frank and Ed to buy a Da Vinci. You know, you look at these toys and you say they start at millions of dollars.
They do.
Pretty impressive to have that here.
Well, that's exactly. When you think of between all the equipment that it takes to treat, it becomes tens of millions of dollars, really.
Right.
And to put that kind of investment in that infrastructure, because it's not even the equipment, it's all the individuals. When you go into a radiation oncology department, I mean, you might meet Tanya and I as your radiation oncologist, but we have people who went to school specifically called dosimetrists to help with the radiation planning, radiation therapists who go to school
The
and are
shape,
certified.
the size.
Right.
Everything to deliver radiation.
The
Physicists who are
physicists,
PhDs
exactly.
to make sure everything is calibrated precisely. It truly takes a village, but when you think of all the additional costs to make sure this all runs, there is an absolute commitment to make sure it's.
So there is somebody
Perfect.
worse than you. There are the mud fuds,
Oh,
the
sure.
MD PhDs, because
Oh,
they
yeah.
not only they added 5 more years.
That's right. That's right.
They really were. I mean, when I used to go down to NIH, I just couldn't imagine these brilliant people
Yeah, they
that
are.
were mud fuds. I said, when do you get to work? By the time you're done, you really are going to be halfway through the normal work cycle.
It's a short career, right?
It's a short career.
But absolutely needed though, because we have to translate all the information from the labs, to clinics, and sort of bring what we learn in one place to patients clinically.
Well, we're seeing it in the research side, where we do gene sequencing.
Yeah, yeah.
And now all of a sudden, learning how to sequence
Right.
becomes a smaller effort
Right.
than taking all the bioinformatic information,
Well, that's exactly it. The
right?
informatics.
And now trying to go back and find out which genes upregulated, which genes downregulated, and looking at libraries to say,
Right.
okay, here's 8 different indicators for cancer, for Alzheimer's.
And that's why having our center affiliated with a bigger center is so important because all that information, if you have biopsies and all of that data, it can all be put into a pooled biobank, and the data will just become exponentially more valuable.
Well, the
and it's
trending
gonna
is
be-
so critical.
Oh my gosh, it's just really.
You know, because I don't want you learning, what few years you have once you graduate. I don't want you taking too many of those to learn what somebody else has already learned over the past few years.
Well, it's interesting because they're changing the curriculums of medical school because of the explosion in information.
Right.
There was a day where you could pretty much cram it all into your head, but it's impossible.
Yeah.
Then you saw this, subspecialization, but now you're training physicians how to sort of plug into the cloud or to the internet or all the other things which are near you and around you. Obviously you have to still have a good foundation, but you can't, there's no way to put it all in your brain any longer. But have to know where to access it so you can bring that information to your patient.
Well, we've talked on different shows about, okay, if you have a specific cancer, is in the old days surgery,
Right.
or, do I nuke it?
Right.
Do I carpet bomb it with chemo?
Right.
How do you look at where to start?
I guess we practice what's called evidence-based medicine. There's been numerous trials where, patients in different, what's called a clinical trial, by a flip of a coin, are going to get one therapy over another. And you kind of build upon that through multiple trials. So you can fine-tune which chemotherapy is going to, be better with the radiation, which outcomes will be better in sequencing, what's the best dose, how's the safest way to deliver. And so, a lot of this work has been done with, sort of patients by flips of coins, which is an amazing thing when you think about how giving and how trusting one must be to participate in clinical trials. Because what you're doing is you're saying, I want to make sure that we all learn. I want help, clearly, but I want to make sure my son and my grandson and my great-great-grandson and my great-great-great-great-grandson or daughter are going to benefit from what you're going to learn from me.
The amazing part is I had a friend who was involved in recruitment. And I said, you have to have the most miserable job. Because if you really believe in your drug, and you're going to do the placebo for this group, and the active treatment for that one, I said, I could not look at the children. If I really believe that what I have works, I couldn't look at a child and put them on a placebo.
Yeah, and that's why we have IRBs, review boards, ethics committees, because these questions can come up, and obviously, hospitals they're very, cautious of what trials are allowed to happen. But the nice thing is, for the most of the malignancies, the majority, this has all been worked out.
Yeah.
And so when patients come in, it's sort of this is what you need, and this is sort of been time tested and proven, and this is what we're going to give you. But it's also nice to know that there's the ability to have access to other stuff with the more rare cancers or more difficult things.
Well, we're seeing more and more work done in like RNA-seq, where they're doing RNA sequencing to say, of the 3 possible clinical trial candidates that you're going to go after, your genetics say this one will be
Right.
most likely the one you'll respond to best.
Yeah, the personalized medicine era, we're just on the beginning of
We're
it.
just
And
getting
it's just
it,
going to
it's
be
just
so,
kind of putting your head up over.
It's so exciting. It's really going to be amazing. And I think that we will see the benefit of it in the next few years. Its growth rate is huge.
And that's always, again, perception. I'm here in Milford. Now, 28,000 of us know it's the center of the universe. 6 billion have to be educated.
Well,
right? But you sit there and say, okay, granted you've got the greatest physicians, the greatest equipment, but wait a minute. If I go into town, do I have access to clinical trial programs versus
Yes.
here
so
you do the best with what you got?
we have clinical trials here as well in Milford, and some of them are offered here, some of them are not. And so if that's the case, we know what's offered in Boston and may not be offered in Milford, and then we'll say to a patient, you know what, you would be perfectly suited for this particular trial. It's going to be a hassle for you, but it's worth it for you to drive there. Or else every once in a while you can get a waiver and get permission to treat the patient here. And
just so
that's
that I
gonna
know
change.
that you're looking and you say, hey, you meet the inclusionary criteria
Right.
for these 3 trials.
Right.
One of them happens to be here.
Right,
2 of them are not.
right.
But if
but they're discussed, and I think that's the beauty of
And
it.
that's the real concern.
Yes, and we've just hired a new protocol, a PhD who's in charge of the protocol. So every single patient consultation that gets called in, that nurse reviews the patient's history ahead of time, and then will come to Peter or me and say, or one of the other doctors, and say, this patient is eligible for these trials. This one's here in Milford, and these others are in Boston. And you can go on from there and take it from there. So every patient is screened for trial eligibility. And I think the other thing...
That's important, because I think people are a little nervous sometimes.
Well, I think the analogy is a spoke in the hub. You know, you have spokes in a wheel, and you have the hub, which might be the main campus, and you might have a spoke to bring Joe to Milford or to another of our cancer centers. But the nice thing is you have a conduit, you have a way, you have a path in, and you have all of that which is offered, if needed, or you don't, but you're offered
You
it,
have
and we're
access.
looking at it.
And you do
access to it.
have people in town who believe you need a passport to cross 128. You know what I mean?
Really?
You're not supposed to cross Boston north or south. If you're
Yeah,
from
it's
north, you
like,
should stay north, south, you stay south.
I
you
need
know.
a passport if I'm going, you know,
To the
and
508 area
495
code.
I
We
grew
were
up here, I
in
know,
a
it's,
review once when somebody, they meant well, but they asked people from the Mass Life Science Initiative if they only worked in Boston. And the poor person looks at, oh no, we go all the way out to Western Mass, as far as Worcester. I had 3 people on the group from Springfield area.
Oh, yeah.
They did not consider Worcester as Western Massachusetts.
Yeah, we do have little blinders on to a certain degree. But it's not a one-way street either. So, you know,
Oh, no.
patients can sort of start here, go there, come back out again, or vice versa.
I think the key is what you said. I don't necessarily need to be treated in Milford. That's an extra benefit.
Right.
Right.
But I dang well want to know that you're looking across the board at all the options.
Right.
Yeah, and then, you know, it happens from time to time. Sometimes a patient will come in and they say, well, you know, I want a second opinion. They go into town, they have the exact same things, it's identical policies and procedure, and they come back out. But, you know, sometimes some people need that, and that's fine.
Right.
That's fine. We encourage it. I mean, it's good. Knowledge is power, and, you know, the better you feel. But I know it makes me feel better, and Tanya, because we direct these centers and we make sure that they're up to par and that, you know, they're best they can possibly be, to know that us and our physicians are paying attention to everything. Because, I mean, you know, truly it goes back to how would you treat your mother? How would you
Yes.
treat your father?
And I think if you keep that perspective, you can't go wrong.
Yeah. And I think, you know, we were talking about, you know, sort of the path of how you see us. And I think the one thing we might have not mentioned is we're radiation oncologists, so we're kind of what we call tertiary physicians. So we're a couple downstream.
Right.
You typically see a primary care doctor, then a surgeon. And then that surgeon will send you to a medical oncologist, and the medical oncologist will most likely send you to us. But it's not, and even in this area, which I think is still baffling at times, there's no guarantee you're going to be referred to see us at the
Right.
Dana-Farber, Brigham and Milford, because of allegiances to other hospitals and other areas and smaller centers. So I think, you know, patients as advocates, looking out for themselves and questioning, you know, where are you sending me? Why am I going there? Why don't I get to go to this basically crown jewel of a cancer center in someplace else? And I think we need to be, I don't know, I think we're all raised that you put doctors on pedestals, and if they tell you, well, you should go do this, well, they must know better, I'm going to. But if you feel like, well, I want to go explore something else, or go to another hospital, get an opinion someplace else, it's okay to speak up and say, wait a second,
Well,
I want
think
that
the
knowledge.
internet's helped a lot.
I was just going to say the same thing. I think, and even since we've been open, it's really evolved. It's changed
It has,
enormously. And patients would, the gone are the days where the patients would say, anything you say, doctor, you know, whatever you tell me to do, I'm going to do. Now it's like, let's go home and Google this and then figure out what's the best thing to do. Or
Well, I mean,
even-
we've bred some hypochondriacs. You know, I've
Yeah.
sneezed, therefore I have cancer. Yeah, but
Right.
the benefit is it's going to make me feel a lot better.
control.
You know, that
Right.
I've looked at the options. And when you tell me I've got to go to Okefenokee, and I sit there and say, why?
Yeah.
I'm not challenging you.
Right.
You know, I'm not going to you saying, Dr. Oreo, I don't believe you. But just, you owe me to give me an educated opinion.
Right.
Or what I'm saying is, because we're so far down the stream of getting to see, you might not be referred to see us. You might have to make the call to come and see us and ask to be seen, or ask one of the physicians to send you over. Yeah, I think, you know, we have all this, we're talking about everything we can offer and how this beautiful, you know, conduit or this beautiful way that we connect with town, but there's still a lot of patients in this Milford area who don't have that luxury, even though they have cancer. They're not getting to the cancer center, and I think we're doing a lot of education work to try to make that.
If I was to say, your Jesuit guilt kicks in, and they instilled it in us, what fundamental question should anybody ask? And maybe not, I'm the one with the cancer, but my wife, anybody supporting me. Okay, I've got a knife, I can go through surgery, I can go through chemo, I can go through radiation. Why are you recommending this treatment? I don't find that insulting to ask a physician. What regime are you proposing and why?
Well, and it behooves us it's our obligation to tell patients what their treatment options are and what the data suggests and what the literature will reveal and which are the best treatments and the side effects and pros and cons of each treatment. So I think that that's really important, and legally you're responsible to do that. That's our responsibility.
Yeah.
But besides legal, you're not legally responsible to say, how would I treat my parents? Right? It's just the right thing to do.
Correct.
Right. Well, and that's the thing. I mean, there are different, you can cut, you can chemo, you could buzz or radiate,
right,
whatever you want to say it, for different malignancies, and the outcomes are going to be similar, but then you have to start to look at side effect profiles. And that's, I think, where the personalization or the individualization of medicine comes into play. You need to really take time and learn about your patient. What's important? If side effect X happened, would that be problematic? Right. Maybe it's not, so maybe this treatment is fine for you. But if that side effect is something that you just do not want to ever face, well, then maybe we should be talking about this treatment. And I think that's where, I think those are the most fun conversations, when you're educating and you're sort of breaking down different options, because really, when someone comes to see you, it's the first time they're hearing about that malignancy and the treatment options. And everything you say is new and it's confusing. And we might have said 1,000 times, because that's what we do. But I enjoy every interaction. It never gets old. It's always fun because you can see eyes brighten. You sort of now understanding, okay, I don't have to fear this. I have a plan, and I understand if I do this, what that entails, or if I do this, what that entails.
Well, I mean, just knowledge. We go through some of the new tests coming out, like NIPT. So instead of harpooning, a mother-to-be to get amniotic fluid, you can take a simple blood test. But you start looking, saying somebody with, how do I say this politically correctly, a large body mass index, where the DNA is not 5% fetal or greater, you can get false readings.
That's a good point.
I need you with your experience, because that I can read. I can look at the gestation period and say, ooh, till I get to 12 weeks. This blood test is not going to be reliable. But I need you to be able to sit down and explain to me, this is why we're selecting this treatment.
Right.
Because it'll make me feel better, if nothing else.
Right.
I don't want to think that, well, you just didn't think about it.
That's exactly, there's so many times you meet people and, they have a friend, family member, a church member who had a different malignancy. And they had different imaging or different workups. They had a PET scan or they had an MRI. And it's like, well, why, doc, I don't want to step on toes, but
why aren't you scanning my pet?
That? Exactly.
How come my pet is not being scanned?
Exactly.
His pet was scanned.
I like it, but that's so reassuring when you explain. Listen, that was for this, but we do it slightly differently for this tumor. But you don't know because where's your reference, right? You're hearing and people are saying, well, you should go ask and get this, but that might not be in your best interest.
I walk in. And in my mind, there's, okay, I would like to be medium rare when you nuke me. Until y'all came on the show and started talking about the physics involved in shaping.
Yes.
Or when you started talking to us about planting the seeds just, right. I mean, somebody like me would never know that.
Yes,
I'm walking in, you're going to nuke me. Okay, I'm laying there, I get hit.
Right. And then people will say, well, what's the difference? Between the machines? And it's not the machines, it's the operator of the machines. It's the same thing as driving a car. Some people are good drivers and other people are not. I mean, it's the cognitive aspect that goes into it is so complicated, and that's where the expertise of our department, but having the expertise of the backup is really so important, because it's very, very technical.
Now, when you mention that sometimes they're sent to Okefenokee Hospital, is that mainly an insurance call?
Sometimes, there are unfortunately, different insurance carriers would prefer you see their individuals. It's, I think we contract with most insurers, but then there's just sort of relationships that, well, why don't you go see my buddy, and, things like that. And, most of the time that's fine, but if one is sort of saying, I really want to know everything, I want to make sure that I'm getting the best care possible, and I know it sounds somewhat arrogant, and I don't mean to be like that, but it's not just me or Tanya, it's the 5,000 people behind us as well. If you want that, then you might have to raise your hand and say, well, okay, I'll go meet this gentleman or lady, but I would kind of also like to go meet those people too. Do you mind? And oftentimes, no. Again, knowledge is power, another opinion, and maybe we're saying the same things, and you want to go someplace else, that's great.
I can see making a decision on, by the way, I'm one of the 3%, and there's somebody at this hospital that specializes, got 100 of these surgeries.
Right.
What I worry more about is somebody said, oh, you ought to go to Braintree. And then you sit there and say, I live in Milford, you can't get there from here. There has to be in my mind, if I'm going to drive to Peabody and start on Tuesday to get there Thursday, there's got to be a significant benefit.
Well, that's exactly it. Because you're putting hardship on yourself. And,
and your family.
Well, everybody. I mean, one, you're not feeling all that great, probably. And then someone's going to be taking care of you and trying to get you back and forth. And yeah, and that's something, that's a tough pill to swallow, quite honestly. Because we realize that we see an awful lot of individuals from Milford, and we're here for the individuals of Milford, but we know we don't see everybody.
Right.
And that might be fine, but you sure would like to make sure, at least screen and say, you're doing okay where you're at,
well,
or maybe you should be here.
We have a lot of immigrants. I mean, I'm from Portuguese descent, and I know that people like my father would never question Dr. Capisi.
Right.
God, asking him a question is like saying, okay, Peter, do you know what you're doing? It's hard to explain to people, it's okay.
Yeah.
Right.
You're not insulting the physician by saying, can I ask somebody else?
Yeah.
Right.
Or why are you putting me on chemo instead of just cutting it out?
Right.
Yeah, or ask questions, exactly it. And honestly, that's the educated patient. It's good. I mean, and that's the thing. I think generationally things are changing, where folks are more inclined, patients are more inclined to say, "Hey, well, explain this more. Oh, give me option A, B, and C. There's got to be something else."
Yeah, I went on the internet last night and read all about this, and the night before, and the night before. So now I have some educated questions.
Right.
Which is fun, which is good. But I think at the end of the day, and I say this to a lot of my patients, especially when we're going through different treatment choices, some that I might offer, some another physician may offer. I want to make sure that they're comfortable with whatever decision they make, whether I treat or somebody else does. If someone wants a surgery, or if someone wants radiation seeds in the prostate or external beam radiation, we go from the outside in. There are 3 different modalities, and there are times when they're all going to be equally effective. But what you don't want to do is go 5 years into the future, and maybe things didn't go as planned, and then look back and said, I woulda, shoulda, coulda, because I didn't spend enough time coming to grips or understanding the treatment decision I made. So, oftentimes I give my patients, phone numbers or emails, call me, this is not the last time. Let's go through this to make sure that you completely understand where we're going with any of these treatments.
Yeah, and I mean, 5 years from now, radiation treatment may advance more than chemo. Let's hope. But like you say, you don't want to be at the point saying, oh, I should have looked further into it.
That's it. I mean, we meet people all the time, unfortunately, who've had one, sort of therapy, and they come to us to kind of clean things up a little bit for, kind of a nice way of saying things. And they say, I wish I didn't jump into this and do that. I wish I came to you first, or I did something else. And, maybe the decision they made wasn't wrong, but they weren't ready to make it, and forever they have this regret. And so I think,
on the other hand, Peter, if 10 years from now I'm having this discussion with you, I'm happy. Door number one's been closed for 10 years.
Oh, no, absolutely. But I mean,
Right.
if you get a surgery and then you're coming back and the surgery didn't work, and now it's like, well, can you fix some of this stuff? Sometimes you're saying to yourself, well, maybe I should have had.
I should have, but you know,
something
at the
else.
end of the day, door number one is still closed.
Right, well,
as long
that's-
as I can argue with you,
No, it's true. You're still.
you know, it's
on
better
right
than the
side of grass.
alternative.
Absolutely.
One of the realities of life today becomes cost. Is there any cost differential at this Farber versus the Boston Farber?
You know, it's funny how we sort of, we're physicians and we try to insulate ourselves from a lot of the costing. I think everything is pretty much equivalent or.
I don't know the
better.
detail.
Yeah, I don't know
Honestly,
the
you're right.
details.
But
Right.
realistically, you're not I mean, Jeff Hopkins always got I laugh. I says, when people come to me and they're hurting, I don't ask if they have Visa or MasterCard. You know, I'm not worried about that. They're in the door, I'm taking care of them.
That being said, I do think that the finances of medicine are in severe need of change, and you know, people come to us and say, well, how much will these treatments cost, or something like that, and that's a really scary question that we don't know the answer to.
But we do have departments that actually work
Yes,
with.
exactly.
And we do that purposefully because, you know, when I have physicians we bring on, and I don't want them to be thinking about cost so much. I want them
Right.
to be
Cognizant.
cognizant, and I want
Right.
them to be responsible and
Right.
not order things which are not necessary.
Right.
But I want them to do what they think is best for the patient.
Right.
But behind the scenes, there are individuals that make sure the insurance will cover everything, and there's a whole different department, so the patient will know this is the cost to me, or the insurance will cover everything. I think it's a fine line, because I do actually do a lot of stuff now with the government, and some of it's tongue-in-cheek, but you know, kind of making sure the reimbursements are fair.
Well, how many times physicians, especially the primary care
Right.
people, have said, I could fill my practice with Medicaid and go out of business
Right.
and starve
Well,
very quickly, because it doesn't even cover
Right.
their true costs. And in the hospital, you know, you can say, well, Ed, you got to bury it somewhere, right? But
That's the reality. I mean, there's a lot of specialties in the hospital that lose money, but there's some specialties that make money, and it becomes, you know, sort of an even, you know, kind of keep
yeah, I
the
remember
doors
the marketing for maternity.
Right.
The maternity ward always seemed to be a moneymaker, so you saw a lot of marketing go in,
open. Right.
because that's got to cover the people who come in and
Right.
just can't afford,
Right.
you know, the treatments that they need.
Yeah. No, it's true. I think, you know, it's our responsibility to make sure we take good care of everybody.
But, you know, on the other hand, I think the ER is probably the most visible. There's no way that Jeff would ever turn away somebody.
Well, legally they can't. I mean, when you're in need, insurance or no insurance, the Impala rules basically state you're going to be stabilized and you're
Right.
going to be, you know, fix the best one can fix you.
But again, when I look at him,
Mm-hmm.
I look at you guys, the legal, yeah, but I just don't think it's in you to turn a patient away.
Yeah. But, you know, the sad thing is, though, maybe not the physicians, but somebody at some point must have for them to enact a law, right?
Yeah, I never thought about that.
You know, and I think it's difficult because, again, as we're talking about, it's a calling, and you know that's what you do. You want to take care of people, and a doctor's not going to turn you away.
And this was why you went into it.
Yeah.
Well, thank you for joining us.
Thank you.
And as always, it's amazing. A linear accelerator in Milford? I mean, you know, you start looking at robotic surgery in Milford. These are cutting edge. These are treatments that are amazing to have locally, that you don't have to go into Boston. As you've heard, you're not challenging, you're not insulting a physician if you ask questions so that you feel better. Our hats are always off to you for bringing all these services to us.
Thank you. It's our
And as
privilege.
always, to our 6 loyal viewers, may God bless, and may tomorrow be a healthier day than today. Thank you.
Far too long since I've been home. Been running all my life just